Good afternoon. I'm Evelynn Hammonds. I'm professor of the history of science and of African and African American studies here at Harvard University. This is the first in a series of conversations that I'm hosting in my role as director of the Project on Race and Gender in Science and Medicine at the Hutchins Center, the Hutchins Center for African and African American Research here at Harvard, on the historical and contemporary impact of the epidemics on African American communities in the United States from 1792 to the present. So I'll be talking in this series with leading scholars in public health, the history of medicine, and African American studies about the historical and contemporary impact of epidemic diseases on African American communities in the United States. Now, obviously, I was inspired to host these conversations in part because of the impetus of our wonderful Professor Henry Louis Gates Jr., but also because the spread of the novel coronavirus pandemic that is now sweeping across the United States is an unprecedented moment in United States history. And until this week, I was surprised that there was so little information in the news about the impact of the coronavirus on African American communities, especially among the poor. And as someone who has studied the devastating and fragmented HIV epidemic in African American communities, I had become increasingly concerned that something similar might be happening with the spread of the coronavirus. In other words, that communities of African American people were at risk and that this was something that was not highly visible in our public conversations. And this week, the headlines began to highlight my worst fears. New data, though it is quite incomplete, has shown that African Americans in a number of cities in the US were dying in greater numbers from COVID-19. And I just want to show you some of the headlines that have appeared. So I'll bring up my PowerPoint at this point. Advance my slides. It's a little bit complicated. My slides are not advancing.
They're not?
They're not advancing, no.
Okay, if you click on it, does it advance?
Ah, it did, sorry.
Okay.
I'll try again, sorry about that.
It sometimes is slow, so just click on one.
Yes, thank you. This is my first time in trying to do this. So, okay, so back to my point. The headlines that have appeared this week include the ones that you see on the screen. Early data shows African Americans have contracted and died of coronavirus at an alarming rate, which appeared in ProPublica April 3rd. The virus is twice as deadly for Black and Latino people than whites in New York City, which appeared in the New York Times on April 8th. The pandemic's missing data. We desperately need to release the statistics on race and ethnicity, also in the New York Times on April 7th. It's a racial justice issue. The headline in The Guardian read, Black Americans are dying in greater numbers from COVID-19, which also appeared on April 8th. And then the coronavirus is infected and killing Black Americans at an alarming high rate, which appeared in the Washington Post on April 7th. And so there's just been an increasing numbers of these commentaries now that emphasize the fact that African American communities are at great risk. So if you see this slide, on the slide from the Washington Post on yesterday, African Americans by percentage of population and share of coronavirus deaths. You see Milwaukee, percentage of the population, African Americans are 26%, the percentage of deaths, 73%. In Louisiana, percent of the population, 32%, percentage of deaths, 70%. Chicago, percentage of the population, 32%, percentage of deaths, 67%, and so on. And not shown on the slide is data from New York City, where it was reported yesterday that the coronavirus is killing Black and Latino people in New York City at twice the rate that it's killing white people. So as I said, it's been really significant to note the ways in which the pandemic, I should say, has now become so significant, and we're now hearing about it. So I thought it was fitting to start this series by talking about having a discussion on epidemics and health disparities in African American communities with my colleague, Professor David Williams. I'm going to introduce David, and we'll talk for about 40 minutes or so. Then we'll take questions from those of you participating online. And then lastly, I'll make some final remarks. So many of you might know of Professor Williams. David Williams is the Florence Sprague Norman and Laura Smart Norman Professor of Public Health. He's chair of Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. He's also a professor of African and African American Studies and Sociology at Harvard University. Previously, he served 6 years on the faculty of Yale University and 14 years on the faculty of the University of Michigan. Dr. Williams is an internationally recognized social scientist focused on social influences on health. He has been invited to give keynote scientific conferences in Europe, Africa, Australia, the Middle East, and across the United States. And his work has been pivotal to our understanding of the complex ways in which socioeconomic status, race, stress, racism, health behavior, and religious involvement can affect health. He's been the author of over 475 scientific papers. So I couldn't think of anybody that would be better to have a conversation with about this new development, or perhaps an old development, of what has happened with the pandemic with respect to African American communities. And so I wanted to begin with David by asking this question. David, you've studied health disparities for a very long time in the United States and abroad. And I want to ask, were you surprised, as so many in the press seem to be, that recently released data show that African Americans are disproportionately affected by the coronavirus pandemic? And if you weren't surprised, why weren't you surprised? David.
Thank you, Evelyn, and welcome to all. This is an honor to be here for this very special conversation at a very difficult time, I think, for the African American and other populations of color in the United States. So I would say I was not surprised at all. That is exactly what I would have expected. The way I think of this, coronavirus has not created health disparities in the United States as a new novel thing. What it has done, it has highlighted and brought to broad relief disparities that are already pre-existing in the United States. These disparities have been documented annually in national reports. There's a report published by the National Center for Health Statistics called Health United States each year, and it documents the disparities. Scholars have actually calculated, because of the racial disparities in health, how many Black people die each year who wouldn't die if there were no racial disparities in health. And if you divide the number by 365, over 200 Black people die every single day in these United States that would not die if the health experience of African Americans was equivalent to that of whites. So this is a pattern that has existed for some time, that is profound, and maybe this is a moment when we can step back and think of what the drivers are and think of what we can do about it.
So that is an important point. I mean, these health disparities have existed. And I notice in the press, though, that many reports are focusing on the high rates of pre-existing chronic diseases among African Americans, obesity, hypertension, diabetes, as the primary drivers of health disparities, and by implication, maybe the primary drivers of why African Americans at this point are disproportionately affected by the coronavirus. But I wanted to ask if you agree that with this focus, are there other factors other than these pre-existing chronic diseases that are actually shaping what's happening?
Yes, there's a complex set of factors. I want to see if I can do this and share my screen for a second, because I want to show you some data. There's nothing like data to bring things to life for us. So can you see my screen?
Yes, I can.
Okay, and what I'm showing you here is national data for the Centers for Disease Control, looking at Blacks and whites and looking at the age at which you get a particular disease. So you could see among persons 18 to 34, 10% of whites have high blood pressure compared to 12% of African Americans. But as age increases among the 50 to 64-year-olds, you can see 61% of African Americans, 50 to 64, have high blood pressure compared to 41% of whites. So there's a big gap there. And if we look at diabetes, you see a similar situation. Let's look at 50 to 64-year-olds in the United States, and you can see that 23% of African Americans at 50 to 64 have diabetes compared to 14% of whites. So the big point is, yes, it is true that African Americans not only have higher rates of death for most of the major chronic diseases in the United States, but they also get them at younger ages. And so if the coronavirus has a greater devastating negative impact on persons who have underlying chronic disease, yes, African Americans will be more vulnerable, because what these data don't show, it just shows one disease. Other research shows that African Americans are not only likely to have one chronic illness, but they have what are called multiple chronic illnesses. If you have diabetes, you're also more likely to have hypertension. However, we need to step back and ask the question, what drives these differences in the first place? Why is it in these great United States that African Americans are getting disease at a younger age? And I would say globally in the world, in virtually every country where we have data, one of the strongest predictors of variations in health is what sociologists call socioeconomic status, income, education, occupational status, and wealth. And so to ground the conversation, let's look at what reasons we can look at that would make African Americans more vulnerable. This is national data for the United States. Median household income in 2015, it's a 2016 report. And I've just translated the data in a way that you can't miss the point. I'm standardizing on the income of whites, household income of whites, as $1. For every dollar of household income white households receive, Asian households receive $1.23. That has to be contextualized by Asian households have more persons contributing to household income than any other group. So if we had used a per person measure of income, whites would have the highest income. In Asian households, 70% of Asians are immigrants, and they come to the United States with high levels of education on average. There are some Asian groups that are doing more poorly than African Americans, among the Laotian and the Cambodian, but as a group, they're doing very well. But so let's look at the historically disadvantaged groups. For every dollar of household income white households received in 2015, Latino households received 72 cents, Native American households 62 cents, African American households 59 cents. Now, what is striking about that 59 cents figure is that it's identical to the racial gap in income in 1978. I did not misspeak. You heard me correctly. 1978 was the peak year of the narrowing of the Black-white gap in income because of the war on poverty and the civil rights policies of the 60s and 70s. And I'm saying in 2015, African Americans are still earning 59 cents to the dollar for whites for median household income. Most of my students think we have made a lot more progress in America than that. And if nothing else, if the COVID virus could wake us up to the stark inequities that exist and how they drive health, it may make an important contribution. I want to show another slide on socioeconomic status to make the point that as bad as the income data show, they dramatically understate the racial differences in economic resources, because income only captures the flow of resources into the household. Right. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. So I looked at the best data I could find, recent data on wealth or median net worth, which is the assets, our savings, our bank accounts, our stocks and bonds, our second homes, all the assets put together. And again, these are the actual numbers, but let's put it in a way we can't miss the point. For every dollar of wealth that white households had in 2016, Black households have 1 dime, 10 cents, and Latino households have 12 cents. So in the context of this pandemic, we are looking at vulnerable populations, economically vulnerable populations that are facing a crisis, that are also working at jobs where and living in places where social distancing can be a challenge.
Yes.
And you have they're also under higher levels of stress and higher levels of co-occurring stress in addition to the stress of racial discrimination. So in one newspaper about the problem quoted me as saying that the COVID virus is a perfect storm for vulnerable populations because there's so many factors that drive poor health that comes together for this population simultaneously.
And simultaneously, what's happening with the way we are choosing to try to mitigate the pandemic are people losing their jobs.
That's
Unemployment
right.
rates skyrocketed as reported this week. And so what was already a difficult situation has been magnified, perhaps exponentially, many, many more times, because these are people who cannot go to work right now.
I agree with you. I think communities of color and poor people are hurt in 2 ways. One is they are overrepresented in many of the essential jobs. The people who are doing the building maintenance, the people who are operating the transit systems, the people who are working in the supermarkets. So they are overrepresented in jobs where they have to work and then are putting themselves at greater risk when social distancing is the ideal strategy. But they're also working at jobs that are more precarious, that are hourly paid, that do not have good benefits. So many of them don't have the luxury, as many of us do, of working from home. Right. So and one of the implications of this for the societal response, the proposed societal response to date has not taken into the account. It's looked at income that households have, and then individuals will get resources based on their income. But my data I just showed you, there are large income gaps. Yes. But then secondly, at every level of income, there are large gaps in wealth. So right. The economic resources also vary dramatically, even at income levels.
So, you've written a lot about, you are a very serious man about data. And you've written that there's a growing emphasis, both within and without the federal government, on the collection of racial and ethnic identifiers in health data systems. with some non-coverage of Asian and Pacific Islander populations. But however, you noted, for all racial or ethnic groups, we need not only more data, but better data. We must be more active in directly measuring the health-related aspects of these social categories. Then, David, how do you explain? You've been doing this for years. I'm not going to say how long, but you've been doing this for years, pointing to the important emphasis of data, but we haven't seen the data hit the front page of the newspapers until this week. How do you explain the relatively slow release of racial and ethnic data with respect to COVID-19 and deaths by the CDC and other state agencies as well?
Yeah, I mean, I think the whole world is focused on this pandemic, and many governors, many political leaders feel the racial ethnic data makes them look bad. But remember, I'm saying this is what happens every day in America anyhow. But I think there's some reluctance to do that. On the other hand, I think there's enough pressure now that everyone is being forced to release the data. And if it can be a wake-up call for America, that would in fact be a good thing. What research shows, although we have documented for more than 100 years that African Americans have lower life expectancy than whites, yes, that a baby born in the United States that is African American is more than twice as likely to die before his or her first birthday than a white infant, more than half, over 60% of all Americans in the United States are unaware that racial ethnic disparities in health even exist. We will never be mobilized to address a problem if we aren't even aware that a problem exists. So this focus, yes.
That's the point I'm trying to make. I mean, we can sit here and open up the PubMed database, and we can find thousands of articles about health disparities. We can find thousands of articles that talk about the need for better data. And you're a leader in this work. You've led data, big projects that focus on this. And then but this is still the case where most people still, and particularly African Americans, don't know. There's got to be a reason behind the not knowing, the silence, the fact that there's so much work done, but not much of that work is visible. And I hope we can turn to what I think you have also said several times in many ways, that more attention needs to be given to the ways that racism in its multiple forms affects health status. We know that social economic status is a central determinant of health status, as you've noted today, but it overlaps the concept of race, but it's not equivalent to the concept of race. But what's been both unattended to is race and racism. So I wonder if you could speak to the fact that this silence, despite all the work that's been done, and we still find that people are reluctant to speak about racism.
Yes, I would say there is great reluctance to speak about racism, and you are absolutely correct. When my career started, most researchers thought that racial differences in health was simply a function of racial differences in socioeconomic status. Mm-hmm. And that if you looked at blacks and whites at the same level of income or the same level of education, race wouldn't matter. In fact, national data for the United States shows overwhelmingly at every level of income and education, there is a racial gap. So if we look at life expectancy at age 25, white high school dropouts at age 25 live 3 years longer than African-American high school dropouts. Mm-hmm. And the gap widens as education increases. Yes. So the gap with higher levels of education is 4.2 years among African-American whites who have a college degree or more education compared to an African-American with a college degree. So both groups benefit from increasing education, but there still is that gap at every level. And one of the more stunning statistics I will just tell you today, in national data for the United States, the best off African-Americans, those with a college degree or more education, still have lower life expectancy, will live a shorter life than whites with a college degree, than whites with some college education, than whites who have finished high school. So those data starkly say there is something about income and education that drives health, whether you're Black, whether you're white, it matters.
Yeah,
but there's something else about race that matters profoundly. And I and many other scholars over the last 25 years have been trying to unpack the ways in which racism affects racial inequality in health. And I want to talk about racism, and I want to talk about the institutional mechanism of racism that plays a role. And I'm going to try to move my slide forward if it cooperates with me here. Okay, I need to. Okay. Okay, yes, great. I want to give you an example of institutional racism just to illustrate the point.
Okay.
This is data from the 2012 congressional election study. How long did Americans have to stand in line waiting to vote in the 2012 presidential election?
Mm-hmm.
And what you can see is that African Americans on average waited 23 minutes to vote, compared to whites waited 12 minutes to vote. None of this reflected individual behavior. It didn't reflect the local precinct workers looking at a Black person and making them stand in line longer to vote.
Yes.
Instead, what it reflected was normal operation of precincts. My slides don't want to move again, but I think if I keep, okay, great. The length of time waiting to vote was not linked to the behavior of individuals, but it was linked to bureaucratic procedures, to institutional policies, to administrative procedures. Where did people vote? And how much budget was allocated? How much staffing was provided? So my important point is, it wasn't the actions of individuals, but it was embedded policies that produce inequalities in voting. Right. And institutional or structural discrimination, as it's called, contributes to racial inequities in health. And one dimension that I have studied and others have studied is residential segregation. Yes. And I want to highlight the work of some of my Harvard faculty in a minute, talking about residential segregation. But first I show this book, historian John Sell from Duke wrote a book on the origins of segregation in the US South and South Africa. He argued that residential segregation by race was one of the most successful domestic policies of the 20th century. Mm-hmm. It's beneath the radar screen. Even Democratic politicians are not talking about it, but it is a driver of inequality. And you would say, well, what does segregation have to do with health in the first place? Well, where you live determines for most Americans where you go to school, the quality of education, determines access to job opportunities, the quality of neighborhood environments, the quality of housing, whether it's a safe place to exercise and whether you have access to nutritious food in your neighborhood, the levels of toxic chemical exposures in your neighborhood, access to primary care, the quality of city services, all of that varies. Drawing on the work of some of my Harvard colleagues here, William Julius Wilson and Robert Sampson, looking at 171 largest cities in America, said there's not even one city where whites live under equal conditions to Blacks. And the worst urban context in which whites reside is better than the average context of Black communities. David Cutler of Harvard Economists, national study looking at national sample of Blacks and whites, shows with rigorous statistical methods, if you could eliminate residential segregation in America, you would completely erase Black-white differences in income, in education, and in unemployment, and reduce Black-white differences in single motherhoods by 2/3. All of these large socioeconomic differences are linked to opportunities at the neighborhood level. Right. And then Raj Chetty, another Harvard economist, doing a large study looking at every census tract in the United States over time, and looks at Black boys and white boys, and look at the census tract in which they are raised. What he finds that Black boys in the second generation will do as well as white boys if they are in a census tract with good resources. The little problem is 99% of all census tracts in which Blacks reside do not provide the opportunities that whites receive. 99%.
That's amazing.
So it is opportunity at the level of the neighborhood, at the level of place, that drives inequities in a powerful way in the United States. And so we need to think of what are the place-based strategies that will create opportunity at a local neighborhood level to drive health. I want to talk about another mechanism of racism quickly that is also relevant for thinking of the coronavirus. It's an aspect of the epidemic that has yet to receive much attention. This is a cover of the book released by the National Academy of Medicine in 2003, entitled Unequal Treatment.
The point is 2003, David, 2003.
2003, you're absolutely correct, 2003. It's called Unequal Treatment. What's the history here? In 1999, at the urging of Congressman Jesse Jackson, the United States Congress voted to ask the National Academy of Medicine to complete a study to answer a simple question. When a Black person or other minority goes into healthcare context in the United States, a hospital, a doctor's office, does your race or ethnicity determine the quality of care that you receive? Remember, the question was not about access to care.
Right.
It was about given access, what's the quality you get?
Yes.
I'm just showing one of the 180 studies this report looked at.
Mm-hmm.
What it found was across virtually every therapeutic intervention, from the most simple to the most complicated, African Americans and other minorities received poorer quality care than whites. Here is one study.
Right.
Dr. Todd was an emergency room physician at UCLA. He asked a simple question. When a Latino comes into the UCLA emergency room with a long bone fracture, that's medical speak for a broken bone in the arm or legs, does your race determine whether you get pain medication? You get the point? Somebody with a broken bone in the ER, does your ethnicity determine whether you get pain medication? He found that 55% of Hispanics who had been treated with a broken bone in the past year had not gotten pain medication, compared to 26% of whites. He was a good researcher. He statistically adjusted for everything else he thought would matter. And at the end of the day, the single biggest predictor of whether you got pain medication was whether you were Hispanic or not. Dr. Todd moved from UCLA to Emory University in Atlanta, repeated the same study in Atlanta, and found exactly the same thing. A Black person with a broken bone in the arm or legs who goes to the emergency department is less likely to get pain medication compared to a white person. Remember, don't focus on pain. This is true for every medical intervention in the United States. This pattern has been best documented in the treatment of cardiovascular disease. What is my take-home point? In the context of COVID-19, where people are working under time pressure, where there is a shortage of equipment and protective gear, a shortage of ventilators, is it likely that Blacks who show up for care will be disadvantaged? They're already less likely to have a primary care provider looking out for them. And these are normal processes of implicit bias that operate. So that's another dimension at which racism could also be affecting the death rates for African Americans.
So that is incredibly powerful. And I'm sure many of the participants in this session today did not know about those, the examples that you gave. And yet there's a residual aspect which you point to in your last comment. The governor of Illinois yesterday, J.B. Pritzker, said, we can't solve the problems that produce the disproportionate impact of coronavirus in African-American communities right now in the midst of this pandemic, because these disparities are the result of decades, maybe centuries of inequality of the application of healthcare to people of color. And what I was struck by is a couple of commentators mentioned, well, there's these inequalities in health and specifically for African Americans are longstanding, but we can't deal with it now. We've got other things that we've got to address. And I think you were in some way suggesting, or at least my question to you is there a way that what we are learning right now can be used to address what some people are calling the decades and maybe even, of course, a century-long disparities that African Americans have suffered from? Is there a way to use it? I can't imagine saying that we have to wait now until this pandemic has passed to make clear what kinds of structural inequalities, implicit biases, explicit biases are at work.
Yes, I mean, they are correct when they say that these are long-standing inequalities and they are driven by long-standing policies. And I'm saying institutional racism is one of them that have produced these inequities. And I think it's really important to recognize and to acknowledge that the higher death rates of African Americans for the coronavirus is not linked to the genes of Black people.
Right.
It's not linked to the individual decisions they have made or their communities have made. We are looking at societal policies producing results that they were intended to produce.
Though there are many commentators who are referring back to biological differences between whites and Blacks as an explanation.
Yes, and that is unfortunate since we are talking about social policies that producing the results that they were in fact set up to do. In terms of what we can do now, I know Martin Luther King talked about the fierce urgency of now. And I think now is a moment of time. I said that most Americans in their day-to-day lives are unaware that disparities even exist. So this bright light that coronavirus has focused on the problem is a moment that I hope those of us in academia can work on, those in policy circles, to try to gain momentum to say, we have a problem as a nation, we can do better, we must do better. These inequities are unacceptable in this great nation, and we are committed to working together to ensuring that every American child has a chance to experience the American dream, that every American adult can achieve and experience the fullness that this society offers. So it's a moment when we can make a difference. The key issue, I want to go back to a historical moment. 1899, W.E.B. Du Bois wrote a book called The Philadelphia Negro.
Yes.
There's a chapter on Negro health in that book.
Yes.
And in it, he documents with the statistics similar to what I showed you, the racial disparities in health. So these are not new. But towards the end of the chapter, he said something profound. He says this: the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race.
Yes.
And Du Bois continued, there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference.
Yes.
That is the stain on America. Yes. What Du Bois called the peculiar indifference. Yes. Scholars today call it the empathy gap. Research in the United States and outside of the United States shows people tend to feel more empathy for the suffering of someone of their own group than the suffering of someone from an out group.
Yes.
So that research in the US shows at age 5, white children do not differ in the pain and suffering they perceive a Black person having versus a white person. By age 7, there's a tendency, and by age 10, it's pronounced. You show white kids the same, a Black person and white person being stuck in their arm with a needle, and the 10-year-olds see the white person as suffering more, experiencing more pain, needing more help than the Black person. So it's a stain on the United States, and I hope that this epidemic and the dramatic loss of life that we are seeing could help to create more empathy for the challenges that African Americans face, so that when there is empathy, we can get political will. Because we know what needs to be done. The question is, how do we do it?
So I'm going to take that as a somewhat hopeful end to how we might think about this pandemic. David, your insights have been absolutely incredible. As a historian of medicine, I've been using, the reason we're going to go back in our next session to the 1793 outbreak of yellow fever in Philadelphia is in part because we're going to move forward from that point to show multiple moments in our history where the epidemics have been disproportionately affected African-American populations. I think African-American intellectuals consistently try to emphasize that these moments might be turned into moments where that empathy gap that you just spoke about might be changed. I would like to be hopeful about this one, but I think when we get through some of the other historical cases, our hopefulness might be tempered. So I want to thank you for your comments and for talking with us today. And then we need to open it up to a few questions in the time that we have left. And those are going to come in through, how am I going to see the questions?
So I've been looking at the chat this whole time, and there are not a lot of questions yet. There are a lot of comments. Let's see. So one is, how do we educate African Americans in poor neighborhoods? One is this social engineering to get rid of the Black non-elite? And I think there are people looking for practical suggestions for ways to move this conversation and movement along.
So could you repeat the first one?
The first one was, how can we educate African Americans in poor neighborhoods?
Okay, so
they have very little access to information that's really pertinent to them.
So David, do you have a comment about that? Because one of the things that I've been struck by, we know from previous epidemics, we've learned a lot about the need to communicate broadly in multiple formats to communities around this country who are at the center of outbreaks of disease. And yet with this one, there was a sense, it seems to me, and maybe it's too soon to make these kinds of comments, but it seems to me that notion that, information should be provided in multiple languages, that information should be given in multiple formats, that we can't expect everybody to be watching MSNBC or Fox News all day long, but there are other ways people need to get the information to understand what puts them at risk and how they can change their own behavior. It's been at least patchy, or at least it's been reported that it's been sort of patchy, even though what we've learned in the past is that those kinds of communications of risk communication of risk to populations has to be done in multiple formats.
I completely agree with you. I think we need to have we didn't have as an effective a strategy as we could have had in terms of providing it. And we have to keep in mind the history that African Americans have been used and abused and taken advantage of by the healthcare system and by the public health system in the United States. So that we need to have a comprehensive campaign to raise awareness levels, and we need to also have communication channels and persons that the community identifies with and that would have credibility with the community providing the message. So I think more could have been done than we did to get the message out.
Mm-hmm.
There are several questions about how we can educate policymakers and what youth can do and what graduate students and medical students can do to educate folks. So I don't know if you want to comment on those. I mean, it's kind of all a lot.
I think we need to think of multiple strategies that can be used to build on the momentum of this high level of awareness and this national concern about the coronavirus. And certainly, I mean, I think our legislative leadership so that if there is another stimulus plan, they really think of who are those that are hurt, and how do we give additional assistance to disadvantaged communities immediately, because the health impact is disproportionate. The economic impact is also disproportionate. So some communities are hurting more than other communities are, and we need to think of how do we get them back on their feet quickly, but we also need to think about what's the long-term strategy in terms of what we are going to do to create opportunity at the local level, to ensure there's access to employment opportunities, to ensure that we can have high quality educational opportunities, elementary and high school, to prepare the next generation to be competitive in the global economy. So there's a lot that we need a short-term strategy for people who are suffering now, but we need a long-term strategy to build on the knowledge that we have, so that we can create better opportunities for the future.
So I would also add that we need a different kind of we need different kinds of ways to educate the public.
I agree.
Both the general public, both policymakers, both other kinds of leaders, because the kind of information that you gave us today, that we've been talking about, in many ways, as you well know, and I do, and many of the participants, we've known that we need to think about what happens to the most vulnerable in an epidemic. We've known that what we need to do for a very long time. We've known that in the United States, a racially stratified society, that African Americans will be disproportionately affected. It's not going to surprise, it didn't surprise you. We began our conversation, it doesn't surprise the rest of us. But that information, there seems to be kind of a gap. There's a lot of information available to people who are well educated, who can see that, probably understand the sort of analytical frame by which we come to these questions, but it's not well understood at the level of the high school curricula or undergraduate curricula, or even graduate curricula outside of professional schools of public health. So it seems to me that there's a lot of information that is siloed that needs to be much more expanded on a regular basis to communities. So people's frame of thinking about these questions, and that it should become normative to say, if there's a pandemic, we need to go find the most vulnerable people because we have to think about them first, rather than weeks down the road, we find out that the most vulnerable are in need of greater resources and attention and visibility.
Yeah, you said it well. I could not agree more. We need to think strategically, and those are some of the things you mentioned are the kinds of initiatives we need desperately. So,
Anne-Marie, can we have one more question, please?
Yes. Let's see. Are there disparities between North and South for African Americans in terms of information and death rates for COVID-19?
I think we are still early in the pandemic, so we don't have data for all the states. We have data for the hotspots. I think one of the hotspots in the South is certainly Louisiana and the New Orleans area, and then African Americans are certainly disadvantaged there as they are in New York City. But we don't have the cases from many other Southern states. In general, we know, if you ask me about health, African-American health in general, we know that the Southern states have a less generous welfare system. If you look at what the payments through family support programs are, and Medicaid coverage and benefits that vary markedly by state. So in general, the Southern states are less generous, and African-American health in the Southern states is worse than it is in Northern and Western states. So, but I mean, it's not just African-American health. Health in general, poor whites do worse in the Southern states as well, because there is less of we don't have the greatest support system in the United States, but it's worse in the South than it is in the Northeast. and West.
Well, yeah, I would agree with that. I think rather than looking at or articulating a sense that we have one public health system that covers the whole United States with a certain kind of equivalence, it's not true. It's a fragmented public health system. And there are certain parts of the country, and as David just said, in the South, where you have fewer resources distributed over various populations, and poor whites and poor African Americans and other poor brown people have a much difficult situation, and that situation doesn't look like what it looks like in New York City. And so I think if there is another lesson we might draw from this at this strange moment in this pandemic, is that the need to begin also to have our political leaders think about the need for real universal public health infrastructure and healthcare as well. So thank you, everybody. We've come to the end of our time. I want to thank all the participants. I want to thank David especially for a wonderful discussion. Thank Anne-Marie Healy and the staff of the Hutchins Center for bringing us all together. I really appreciate it. And I hope next week, as I said, I'll be talking to Professor Raina Hogarth, who's a professor of history at the University of Illinois. And we're going to be talking about the 1793 yellow fever epidemic in Philadelphia, where class and race and politics were so central to a story of one of the most significant epidemics of yellow fever, epidemics of any kind in early America. What it taught us, I hope it taught us, about these issues, I think you'll find there are many resonances to what we were talking about this afternoon. So thank you all, and hope we see many of you next week.
Thank you.